We are going to start in 3, 2, 1. Hey there, Warriors. Thanks for tuning in. My name is Carlos Saavedra, Senior Communications Officer for the Office of Advancement at the University of Waterloo. Today, we have a very exciting talk lined up. Not only are we going to be talking through the current state of the global response to COVID-19, but we will also talk about what happens next, both in the short term and the long term. And to take us on that journey is my guest and fellow alumnus, Dr. Rohit Ramchandani. Thanks for joining us.
Thanks, Carlos, for having me.
So Dr. Ramchandani, he is a 04 Bachelor of Science in Health Studies and Gerontology grad from the Faculty of Applied Health Sciences from Waterloo. He went on to do his Master's of Public Health at Boston University and his Doctor of Public Health at Johns Hopkins Bloomberg School of Public Health. He is founder and CEO at Antara Global Health Advisors, a global consultancy that provides technical expertise and evidence-based public health and management advice to public and private organizations around the world. He is also an adjunct professor in the School of Public Health and Health Systems at Waterloo, and he is also the co-lead for our Toronto Alumni chapter. So quite the CV. So, Dr. Ramchandani, you're a very busy man right now, so I appreciate you taking some time to talk with me today.
My pleasure.
So, we are going to get right into it. So, I was wondering if you could set the stakes for us, set this foundation, and give us an overview of the pandemic right now, and if you could provide some insight into the current status in terms of the numbers globally.
Sure. So I guess as of yesterday, April 27th, according to the Johns Hopkins COVID-19 tracker, which is probably one of the best dashboards in the world right now in terms of tracking this pandemic, there are now over 3 million confirmed cases globally, with just over 212,000 confirmed deaths. About a third of those reported cases are from the United States, about 200,000 each from Spain and Italy, about 160,000 each in France, Germany, and the United Kingdom. And then it kind of goes on from there. So Turkey, Iran, China right now has about 84,000 reported cases, Russia, Brazil, and then Canada in that order. And we've reported almost 50,000 cases here in Canada. If we look at mortality figures, just looking at the number of deaths, we have the U.S. Leading the pack with over 56,000, Italy with almost 27,000, Spain and France each with over 23,000. The United Kingdom, Belgium, Germany, and Iran with around 6,000 each, China with almost 5,000, and again, it goes on. In Canada, as of yesterday, we've confirmed 2,841 deaths, with well over half of those deaths being linked to long-term care facilities or some other kind of institution, retirement centers, prisons, rehab centers. Now, we have to remember that while one of the most important ways to measure the burden of COVID-19 is obviously mortality, countries throughout the world have reported very different case fatality ratios, which is different from the raw number of deaths and is calculated by looking at the number of deaths divided by the number of confirmed cases. And if we look at it from that perspective, the countries that have the most deaths proportionally to their COVID-19 cases are Belgium, with a 15% observed case fatality ratio, France, UK, Italy, Netherlands, Spain, Iran, US, and then China and Germany, with a 4% observed case fatality ratio. Right now in Canada, we're seeing about 5.6% observed case fatality. Now you could look at that same number of deaths, but change your denominator to be over 100,000 for every 100,000 people in the population, and the ordering of those countries will shift a little bit. So there's a lot of ways, I guess, to look at these figures, and I guess the message there is that, we shouldn't be relying on any one indicator or figure to really understand the scope of this thing. We also have to remember that a lot of these comparisons, especially between countries, are somewhat irrelevant because what's reported is very much dependent on a lot of different factors. So, for example, the degree of testing that's taking place in each country. With more testing, more people with milder cases also tend to be identified, and this will lower things like the case fatality ratio. The demographics of a country make a big difference, right? Mortality will tend to be higher in countries with older populations. Characteristics of the healthcare system make a difference, right? Mortality might rise where health facilities become overwhelmed and have fewer resources. The definition of what constitutes a case makes a difference. So an example might be the initial case definition in China included pneumonia and was later then adjusted to include people with milder clinical presentation. So that simple shift in definition will make the number of cases jump. And then there's like political lags and transparency of data reporting, of course, including time lags, etc. And I'd say that, testing is probably one of the most relevant factors here. It's important for us to remember that the rate of confirmed cases and deaths can't be higher than the rate of testing, right? So the rate of testing in a country is its ceiling in terms of understanding the degree of this epidemic. And in many countries right now, that ceiling is very low, which means that these kinds of cross-country comparisons are limited if they aren't presented within the context of how many tests a country is actually conducting. The fact is that where there's no or little testing taking place, there aren't any counts of confirmed cases and confirmed deaths. And there's a great analysis that was just released by the Financial Times showing that the number of COVID-19 related deaths might be almost 60% higher than what's actually being reported in official counts as a result of low testing. They looked at the number of deaths overall from all causes across 14 countries, which show major spikes in mortality when compared to historical averages. And those mortality statistics, they found 122,000 deaths in excess of normal levels across those 14 locations, which is considerably higher than the 77,000 official COVID-19 reported deaths for the same places and time periods. So as an example, they showed that overall deaths have risen 60% in Belgium, 51% in Spain, 42% in the Netherlands, 34% in France during the pandemic compared with the same period in previous years. And with some of those deaths might be the result of causes other than COVID-19, because people are avoiding hospitals for other ailments. The level of excess mortality has risen most steeply in places suffering the worst COVID-19 outbreaks. And that suggests that most of these deaths are directly related to the virus rather than some other kind of side effect from lockdowns or whatever. And many of those deaths haven't been counted as COVID related. So, I think the bottom line here is that we can't count what we don't measure. And it's, and so I guess it's very important that all countries, we be very focused on scaling up their testing right now. And I guess in line with that idea, there's a lot of variability in terms of how different countries, cultures, societies are dealing with this pandemic. And I'd say the positive is that there's, this unprecedented amount of scientific collaboration and sharing taking place now. And many countries are trying to take the best of what others further along their epidemic curves have figured out, learning from what's worked. But things are changing every day, and there's still a lot that we're learning. And to stay on top of it is really kind of a bit like drinking from a hot fire hose, There are authors like Frank Snowden, who is a professor of the history of medicine at Yale, and he wrote a book called Epidemics and Society, and has shown historically how our social structures have allowed diseases to flourish. And this idea that, epidemics aren't random events that afflict societies arbitrarily and without warning. In fact, on the contrary, every society produces its own specific vulnerabilities. And he notes that to study them is to understand that society's structure, its standard of living, and its political priorities. And so, I think epidemics like this one can really be a mirror for humanity, reflecting the moral relationships that people have towards one another. And I think we're definitely seeing that idea in action now.
Now, you mentioned that there's a lot of learning going on between organizations and governments. And we're going to speak a little bit about what we do with that learning in the future. But I want to take a step back and ask you, how did we get here? What is the origins of the COVID-19 virus, and what can we learn from it?
Yeah. Well, I guess, let's start with the fact that viruses, require a living cell, a host, in order to multiply, right? They largely consist of genetic material like either DNA or RNA wrapped in a protein coat. And these DNA and RNA sequences can change over time, accumulating modifications to the genetic code that favor the survival of that virus. And so we can look at these genetic sequences to estimate how different viruses are related and how they might have evolved over time. And we've seen an increasing number of emerging viruses, right? Viruses that are rapidly changing in terms of their geographic distribution or their incidence. And these viruses emerge often unexpectedly amid some level of mystery about, where they came from and why they're spreading. And their origins are often more complex than they might appear. And that's really where epidemiology comes in, as a scientific kind of systematic and data-driven study of the distribution and determinants, causes, risk factors, origins of health-related states and events, including diseases in specific populations. So some viruses like West Nile, for example, are spread by insects and arachnids, right? And these are known as arboviruses. And their distribution is being highly affected by things like climate change and global warming, which is really helping with their emergence right now. A significant proportion of emerging viruses are zoonotic viruses, which are spread from animals. And these viruses are perhaps even more unpredictable because that interaction between animals and humans is critical to their spillover into human populations. So the domestication of livestock, as an example, has allowed a lot of species, all with their own viruses, to come into close contact with humans, which has created the right conditions for zoonosis. So poultry and pigs, for example, are well known for a generation of a lot of new influenza viruses. You've probably heard of, avian influenza and swine flu and the like. So human encroachment into new environments and the disruption of wildlife can also lead to humans being exposed to animals and their viruses. So outbreaks of Ebola virus, for example, have often been associated with the bushmeat trade, with the primary host suspected of being fruit bats. Bats will also kind of drop partially eaten fruits and pulp, which land mammals will then feed on. And this chain of events forms, one kind of indirect means of transmission from the natural host to animal populations. And so I sit on the board of directors of the Jane Goodall Institute, and this is one of our many areas of focus is really putting an end to the bushmeat trade, including for chimpanzees in particular. And so deforestation and the sale of live wild animals or bushmeat make the emergence of new viruses somewhat inevitable, while population growth and then dense urbanization and human migration make their spread that much easier. So in the case of COVID-19, we think the virus leapt from bats to possibly an intermediate host, potentially a pangolin, and then on to humans. Pangolins are actually considered to be one of the most highly illegally trafficked mammals in the world because their scales being used in traditional medicines and they're also used for meat. And so this is just like the original SARS virus, which jumped from bats to civets before making its way into humans, and for MERS, Middle Eastern Respiratory Syndrome, where the virus infected camels before spreading to humans. And these are things that have been verified by independent studies, looking at kind of telltale features of the virus through genome sequencing and phylogenetic analysis, which show with a very high degree of probability that the virus is the product of natural evolution, certainly ruling out any rumors of laboratory manipulation as a potential origin, which is one rumor I know a lot of people are hearing about. There's more certainty in bats being the reservoir for the virus, but still uncertainty around the intermediate host and whether there was an intermediate host. But a number of independent studies have identified like 96% sequence similarity between COVID-19 and a particular bat coronavirus strain. So that's highly suggestive of the source of this thing being a bat. We also know that the virus's emergence is associated from a timing and epidemiological standpoint with one of the largest wholesale seafood markets in central China, located in Wuhan, which also reportedly sold wild animals. So, and there's been some good studies and analysis. So there was this analysis of the first 41 COVID-19 patients in the Lancet, which is one of the world's most renowned scientific journals, that found that 27 of them had direct exposure to the Wuhan market. But the same analysis then also found that the first known case of the illness didn't have any connection to that market, raising questions about the possibility of a transmission event independent of the market. So there's still, research and follow-up taking place to fill in some of the gaps that we still have. And then I guess maybe just to conclude, the fact is that it's an evolutionary certainty, that more viruses will leap into humans with the potential to cause more pandemics. And this is why it's so important to have more and better surveillance systems in place, and particularly in the areas where they're most prone to emerge. And those are namely places like, deforested areas, environments under stress from climate change, locations where the consumption of wild animals is prevalent, where there are high density populations. And what that can be boiled down to is that it's just so important to ensure that we have resilient health systems in every country around the world, with strong surveillance and reporting systems in place that are really able to reach out to their rural peripheries, so that's kind of what we know so far about how it all started, and it's now in 185 countries and territories.
And definitely want to get back to the idea of surveillance and reporting when we look at how we can better and improve on our existing systems that we have in place. But when thinking about COVID-19 and earlier on, making it very hard to detect was the characteristics of the virus and the idea that it very much resembles the common flu. Could you explain a little bit what really is the difference between the common flu and the COVID-19 virus?
Yeah. So I realize there's still a lot of people questioning how dangerous this virus really is, and does it, or did it warrant this response? And the short answer is yes, it is different enough and it is dangerous enough to have warranted this response. And we have to realize that while there are recognized similarities and differences between COVID-19 and the flu, there's still a lot that we don't know about the novel coronavirus. And there's new research coming out every day. A lot of it is being posted online in draft form, not having gone through full peer review because of the need to have fast access, right, to data right now. But that comes with certain uncertainties and a greater potential for retractions and weaknesses in study design not being caught right up front. So the learning process is very interesting right now, just to say that. That said, there are a number of things that we do know. Both the flu and COVID-19 are infectious respiratory illnesses. Their symptoms can look somewhat similar, presenting as a kind of wide range of illnesses from asymptomatic or mild disease right through to severe disease and death. Both can spread from person to person through droplets in the air from an infected person coughing or sneezing or even talking. And as a result, the same public health measures like regular hand washing and good respiratory etiquette, coughing into your elbow or into a tissue and then disposing it are important actions that everyone can take to prevent infection. Another important factor is that it seems that they can both be spread by an infected person for several days before their symptoms appear, what's called asymptomatic spread, which is an important factor, but we're still discovering to what extent asymptomatic spread is playing a role in COVID-19, and it's still not fully understood. But then there's also a number of differences, and they're actually caused by flu and COVID-19. They're caused by different viruses. The flu is caused by any of several different types of strains of influenza virus. COVID-19 belongs to a family of coronaviruses, 7 of which infect humans, including this one. 4 of them have been annoying humans for more than a century, causing like a third of common colds. The other 2 are MERS, like I mentioned earlier, Middle Eastern Respiratory Syndrome, and the original SARS, which, like COVID-19, both cause far more severe disease than the other 4. Another good way to understand the difference is to look at a measure that epidemiologists call the reproduction rate, or R naught. And this can be thought of as a measure of how contagious a disease is and how easily it spreads. So essentially what the R naught does is it measures the number of additional people who can be infected from a single earlier infected person in an unvaccinated population. And while it can be somewhat hard to measure and is variable from outbreak to outbreak, depending on the context, right, including population and technology, the degree of response, etc., we know that when it's below 1, the number of cases is going down, and when it's above 1, the number of cases is going up. And so an R naught of 1 means that each infected person will pass it along to one other person. So if I kind of, to make that a little clearer, I guess, is, so if I get the normal flu, on average, I'm going to infect approximately 1.3 other people. If those people give it to the next group, that's the second time it gets passed along. And by the time that's happened 10 times, I've been responsible for approximately 14 cases of flu. This coronavirus, COVID-19, is much more infectious. So current estimates are that the R naught for COVID-19 is somewhere between 2 and 3. Some models show it to be even higher. So if we use 3 and each positive case passes it on, and that happens 10 times, that initial case has now been responsible for infecting 59,000 other people. So that's kind of how the reproductive rate works. It also appears that mortality for COVID-19 is higher than for influenza, especially seasonal influenza. So while the true mortality will kind of take time to fully understand and get an accurate figure on, it's shifting and it varies from country to country. The data we have so far indicates that the case fatality ratio, the number of reported deaths divided by the reported cases, is probably between 3 and 4% globally. For seasonal influenza, mortality is usually well below 0.1%, with the caveat that this is to a large extent determined by access to and quality of healthcare. So if you take the reproductive rate and this case fatality rate within the context of asymptomatic spread, you begin to get a sense of why COVID-19 is so much more difficult to control. And that's partially why it's emerged as a global pandemic.
And the idea to eliminate the spread and to kind of stop the domino, the next domino in the sequence, so that domino doesn't affect the others. A new concept has kind of come up, social distancing. I think everyone now knows of social distancing and flattening the curve. Could you explain a little bit about what that is?
Sure. Yeah. So at this point, like you're saying, everyone is probably quite familiar with these concepts and are in fact now living proof themselves of why these concepts work. Earlier I mentioned the reproductive rate and how COVID-19 can spread from one person to 3 people to 9 people, etc. Now, most of those people are going to feel a bit under the weather, but they'll be just fine, right? But they'll have spread it around, and a few will get more sick. So they'll need to go to a hospital. And when they're in the hospital, they're going to consume resources and time, and people will look after them, quite rightly. There, they'll be monitored to see if they become really sick. Those people will then go on to an intensive care unit. And that's where, if you're critically ill, your life gets saved or not. So this is the issue when we've got a limited resource, right? Which we have in this case, a limited number of ventilators, personal protective equipment, tests, doctors and nurses, which is fine because we can't run ourselves with huge excess capacity all the time. But if we overwhelm all of this, we can't provide that service of caring for people properly, and while it'll be a relatively small proportion of people who get really sick and hospitalized, right now I think it's like 17% of cases in Canada right now, which actually isn't that small, and a smaller percent still of those who will need to go to an ICU, approximately 3 to 4% of cases in Canada, will save the lives of a large number of those people. But we have to remember that the best chance we can give to the people who do fall ill is if we have enough beds and staff, available equipment to be able to be there for them, right? This is what flattening the curve is about. It's about kind of slowing the spread and not overwhelming the system. And we're all playing a role in ensuring that right now. In the first phase of the pandemic, we saw an exponential spread of the disease in a number of countries, starting with China and then throughout Asia and Europe and North America, and now it's ramping up in Africa. The number of infections was continuously doubling. So in Canada, the rate of doubling changed from every 3 to 4 days during the second half of March to doubling about every 5 to 8 days in early April. And right now, the current rate of doubling is about 15 days. So if people's behavior hadn't changed, then most of the population would have been infected. But by changing behavior, many countries have gotten the infection rate to plateau and to start coming down. And that's the direction that we're headed in now. And so, we can take Ontario as an example. The current wave, there could be more, which is a very legitimate concern. But the current wave of new community spread cases appears to have peaked. Although outbreaks in long-term care settings and other institutions kind of continue to be a major concern, more generally, we've avoided a significant surge in cases. So all the kind of sacrifices that everyone's making are working right now. It's also probably worth noting that peaks aren't necessarily a nice kind of single spike. They can be bumpy and they can extend for some time. So it's not to say that we're out of the woods yet. The key to further reducing the number of cases and deaths is really to kind of continue to adhere to public health measures, including staying at home and practicing physical distancing. Right now, I think one of the biggest threats is complacency, right? We're already seeing resurgence in a number of places where the curves had started to come down as localities kind of begin to loosen up restrictions. So I think it's just really important to emphasize staying the course and to approach reopening very carefully.
Yeah, and I think as the weather starts to warm up here in Ontario, everyone has that idea to go out and to see family, to have a few barbecues. But yeah, definitely need to stay the course. I've got two little ones who are asking every day if they could see grandma and grandpa, but it's tough. But we know that we need to do our part to flatten the curve. But on that note, how does this thing end? Is there light at the end of the tunnel? What does our path look like moving forward?
Yeah. So let's start with the fact that there's really no path to ending a pandemic other than a vaccine, and current estimates are that that's likely to be 18 to 24 months out, and we can't talk. We can talk more about that in a second, but I think in the interim, there's a lot we can do to get this thing under control and get back to some modified new way of public life. But it's really predicated on whether we collectively take the right steps and realize that science has to lead our exit strategy. But that said, how to relax the lockdown is not something around which there's scientific consensus yet. And so it's likely that reopening society is going to be a long haul with a lot of trial and error. It's going to have to be something we take baby steps with. And that's really reflected in the kind of staged approach that we're seeing in the roadmaps being released by various localities. So here in Ontario, the province just released a high-level roadmap yesterday, which basically outlines what types of things they're going to be looking for prior to easing public health measures. So they're looking for things consistent 2 to 4 week decrease in the number of new cases, a decrease in the rate of cases that can't be traced to a particular source, a decrease in the number of new cases in hospitals, making sure they have sufficient healthcare capacity, right, including the number of ventilators and personal protective equipment, ramping up our capacity to ensure that at least 90% of new COVID-19 contacts are being traced by public health officials within 24 hours. So ramping up that capacity. Ongoing testing of suspected cases, especially of vulnerable populations, so that they can kind of detect new outbreaks quickly. And hopefully that expands beyond just suspected cases. I think we need to aim for broader testing across a representative sample of the population with, sample sizes in the thousands to pick up cases that may not be showing symptoms and get a good sense of what the spread actually is. And then also they're looking for a kind of a shift. They're thinking about a shift to new ways of testing and contact tracing to promote widespread tracking of cases. And there's opportunities to leverage cell phones and other technologies to do this, as a number of countries have done with a lot of success. But simultaneously, a lot of discussion and debate around data ownership and privacy and how to do that in an ethical and time-bound kind of way. Alternatively, we could just go old school and fund, public health departments and volunteers to do in-person contact tracing. Likely, the direction we need to go is probably some combination of the two. And as they lift public health measures and resume economic activity, once these aforementioned things are in place, they're going to do so in 3 stages. Each of those stages will last between 2 and 4 weeks, and they're looking at things like, which businesses can immediately meet or modify their operations while adhering to public health guidance. Using things like curbside pickup or delivery, or they'll start with opening some outdoor spaces like parks. Allow for a greater number of individuals to attend certain events like funerals. Hospitals will start to offer scheduled non-urgent surgeries again. Then, if that goes smoothly without seeing any kind of resurgence, they'll look at opening different workplaces based on risk assessments and maybe some larger public gatherings. And then eventually, we move to all workplaces and further relax restrictions on other public gatherings. That said, I think the largest types of public gatherings like concerts and sporting events are likely to kind of remain off the table for the foreseeable future. The plan also acknowledges the need to minimize outbreaks in special settings like nursing homes, which is definitely a weak spot in Canada right now. But efforts finally seem to be underway to try and address what up to now has really been a failure of our system to protect our elders. So stopping long-term care staff from working in multiple facilities as a way to slow the spread of the virus is certainly one step that has helped, but we'll need to continue limiting visits with seniors and ensuring other prevention measures stay in place for some time. They also obviously mentioned the reopening of schools, but haven't provided a lot of detail at this point. And I think what we need to keep in mind is that while kids seem to be less susceptible to COVID-19, they're also very well equipped to transmit it. So we're going to have to be careful with that one. And if I'm honest, I'm really not holding my breath in terms of my kids going back to during this current school year anyways. During all of these phases, the plan is to maintain physical distancing and hand washing, along with self-isolation when experiencing symptoms. The plan also encourages continuing remote work arrangements where those are feasible. And we won't move from one stage to the next if there's any signs of a resurgence in cases. This will obviously continue to get more detailed and nuanced as time goes on. They'll start to fill in details. You can, go fishing or camping or open a golf course, et cetera, et cetera. I know people wanted to see dates and perhaps something more concrete. But for now, I think it's an appropriate acknowledgement that there's uncertainty in what lies ahead, and it places the right kind of emphasis on ensuring we have the right public health resources in place to reopen the economy. So this roadmap also seems to be in line with the requirements for reopening suggested by the World Health Organization, which additionally notes the importance of managing the risks of importing cases from outside the country, as well as ensuring local communities are educated and engaged and empowered to adjust to our new normal. And we're doing both of these things for the most part pretty well in Ontario and Canada. I think we're still a ways out from reopening the border to non-Canadians, but what's certain is that before we do, being able to screen potential visitors with point of care testing at airports, making it easier to identify carriers and having functioning systems to quarantine people for 14 days will likely have to be in place before we do that. And we'll likely also see more targeted travel restrictions for visitors from specific countries, depending on how they're managing the virus. But this, of course, can get politically messy. one can only imagine how that might look with regard to our neighbors to the south, right? No matter what, I think we're going to have to accept, like we did with security protocols after 9/11, that there are going to be changes to the way that we travel. So overall, I think the thing we have to realize is that it takes longer for the curve to go down than it does for it to come up. And so control measures really have to be lifted more like a dimmer switch rather than a flick switch, and it's a combination of testing, isolation, tracing, and continued physical distancing that's likely to enable control of COVID-19 with the least disruption. I also think that no matter what decisions we make politically or from a public health perspective, amongst the biggest unknowns of this kind of post-lockdown period will be how each individual chooses to behave, right? Not everyone's going to immediately resume the activities that are allowed. It will, it'll take a lot of good communication so that people understand what the risks are and feel comfortable going back to work or school. And that too will be a gradual process, with some people immediately doing everything that's allowed and others taking it more slowly. Some employers will probably take a number of months before they require workers to come back. And some people will want the restrictions lifted more rapidly and may choose to, even break the rules, right? Which will put people at risk. So good communication and compliance, I think, will be key. Another important part of this is that I think we need to be wary of arguments that, pit health versus the economy. There's a lot of good analysis that in the long run, if we end up with uncontrolled spread of COVID, the economy will take a much, much longer time to recover. And we already know that you can't have a healthy economy without a healthy workforce. We have to take it to heart that the path back to a functional economy really runs through sound public health measures. And so I guess just to kind of wrap this up, I started by mentioning that in the longer term, the best chances we have of beating this pandemic is to develop a vaccine and vaccinate most of the population. The fact is that while treatments can save lives, vaccines save populations. And that's why they're such a critical part of the public health toolkit. And that's because with vaccines, you can stop the transmission chain, right? So if you can vaccinate and make sure people become non-transmitters, where they don't develop the viral load sufficient enough to pass on the virus, then you can get that herd immunity effect. In other words, the resistance to the spread of a contagious disease within a population that results when enough individuals have immunity. And let me just say here that, this whole notion of letting the disease spread through the population until people acquire natural immunity is just not a viable option, right? It would mean millions of unnecessary deaths and is inhumane in countless ways. This is something that was being floated in the UK for some time, and the notion received a lot of backlash, and rightfully so. I think somebody noted that this strategy should have actually just been called pandemic cleansing. So vaccination is really our only viable route to herd immunity in this case. And historically, vaccines have saved more lives than any other tool in history. Smallpox, which used to kill millions of people every year, was eradicated with a vaccine. And they've played a key role in reducing childhood deaths from, I think it was like 10 million per year in 2000 to less than 5 million per year today. And with regard to the development of a COVID-19 vaccine, we're really seeing an unprecedented level of scientific collaboration taking place around the world right now. This is an area that we're very kind of engaged in from a research standpoint, in just kind of monitoring the processes around getting a vaccine out. So as an example, Chinese scientists published the genetic sequence for the virus on January 10th, and scientists from all over the world were able to start analyzing that sequence almost immediately that Friday. And by Monday, there were teams of researchers who had already isolated and designed potential candidate antigens for the vaccine. Today, according to the WHO, there are already 5 vaccine candidates in clinical evaluation. That means either phase 1 or 2 trials, and another approximately 71 candidate vaccines in preclinical evaluation, which means they haven't yet started phase 1 trials. And just to give you a sense of what that whole process looks like, we start with making a candidate vaccine, testing it in animals, right? These are preclinical stages. Then we have safety and testing in small numbers of humans. This is phase 1. Safety and efficacy testing in medium numbers of people. That's phase 2. And then safety and efficacy testing in large numbers of people, and that's phase 3. And finally, then you have regulatory approval and building manufacturing while registering the vaccine in every country. Now, unfortunately, this whole development process to get a vaccine against a new disease takes well over 5 years and typically even longer. So developing a vaccine for COVID in 12 to 18 months or from 18 to 24 months, which we believe is doable, would be a historic event in a number of ways. Many of these vaccine approaches will fail because they won't generate a strong enough immune response to provide protection, particularly in older people whose immune systems typically don't respond as well to vaccines. And so a number of candidates need to be funded so that they can advance at full speed, so that we can double down on the best bets and maximize the chances of finding a few winners. The goal is really to pick the 1 or 2 best constructs and vaccinate the entire world. That's like 7 billion doses if it's a single dose vaccine, and 14 billion if it's a double dose vaccine. And because of the rush to get them, the scale of the manufacturing needs to be like nothing we've ever seen, and we'll probably have to involve multiple companies and facilities, around the world. And the issue of safety is obviously another very important factor. So regulators worldwide have to work together to decide how large the safety database needs to be to approve a COVID-19 vaccine. And I guess the final point to make here is that equitable vaccine distribution is essential to achieving herd immunity, right? So at least for the first 8 to 12 months after a vaccine becomes available, it's likely that there's going to be only a limited supply to meet global demand. So there needs to be a global agreement on allocating stocks to countries around the world. Vaccines and antivirals can't just be sold to the highest bidder. If that were to happen, the result will be political tensions like what we're currently experiencing over allocation of personal protective equipment and ventilators and test kits. So these products need to be treated, as global public goods, and they need to be available and affordable for people who are at the heart of the outbreak and in the greatest need. Those are, frontline health workers, countries that are experiencing the brunt of the pandemic at that time, etc. Right? Not only is this approach to distribution the right thing to do, I think it's also the right strategy for cutting transmission and preventing future epidemics or future pandemics. In general, we're really going to have to focus on low and middle income countries where we already know there are challenges with supply chains, access to vaccination, civil registration and formal identification, limited health funding, weaker health systems. So global coordination obviously will be key to this, and that's one area of research that we're very involved in.
So you mentioned the supply of vaccines for low and middle income countries. You're a professor of global innovation at the University of Waterloo. Could you share a little bit about what the outlook is for developing countries? We hear a lot in the news about what's going on in Canada, the UK, the United States, but in low and middle income countries, what's the outlook?
Yeah, well, I think a lot of people are very focused on what's happening in their own countries right now. But I think one thing that this pandemic has really clearly shown us is how small the world really is. Even the most self-interested person or nationalistic government would probably agree with this by now. So this pandemic has shown us that viruses don't respect borders, and that we're all interconnected, whether we like it or not. And if we look at this from a broader perspective, whatever long-term solution we develop has to be built through a global lens. It's really the only way to effectively end this pandemic and prevent future ones. So we can only kind of border ourselves off for so long, right? And sure, we can wait till everyone in the world is vaccinated against COVID-19, but that'll have major economic and other repercussions. And it's just a matter of time before there's another emerging disease on the horizon, right? And that's partially why we're hearing so much right now about concepts of shared responsibility and global solidarity. But for many developing countries, this crisis is just getting started. And the human toll of a major COVID-19 outbreak would be orders of magnitude larger than any advanced economy. This pandemic is a huge threat to the world's poor. There's obviously the direct threat from the virus, but there are other looming secondary threats that are just as concerning, with a lot of new challenges emerging as the virus spreads into these countries, both social and economic. Right now, the pandemic is halting delivery of essential services such as antenatal care visits, attended births, delivery of childhood vaccinations, and access to family planning, which have been key drivers in recent global reductions in maternal and child mortality. And so these disruptions are likely to lead to major increases in preventable maternal and child morbidity and mortality. And new estimates from some of my colleagues at Johns Hopkins suggest that under a scenario in which COVID-19 causes similar disruptions to what we saw in West Africa during the Ebola outbreak, almost 1.2 million children and 57,000 mothers could die over just the next 6 months. This would represent a 45% increase over existing child mortality levels. And so it's also important to note that the COVID-19 playbook that wealthy nations in Europe and Asia and North America have come to know by this point, stay at home as much as possible, keep a 6-foot distance from the developing from each other, wash hands often. These will be nearly impossible to follow in much of the developing world, right? In poor countries, there are just fewer jobs that can be done remotely. The UN Development Program has noted that 75% of people in the least developed countries lack access to soap and water. Much of the population lives in high density urban settings with multiple people living under one roof, which could also make it much easier for the disease to spread. Income losses are expected to exceed $220 billion in developing countries, and with an estimated 55% of the global population having no access to social protection, these losses are likely to impact not only health, but education and human rights, in the most severe cases, basic food security and nutrition. The UN World Food Program, for example, they've warned that an estimated 265 million people could face acute food insecurity by the end of 2020. And that's up from 135 million people before the crisis. So these are really things, that I think we need to be looking at closely. Certainly from a health perspective, under-resourced hospitals and fragile health systems are likely to be overwhelmed. So as an example, Italy's health system has been overwhelmed with one doctor for every 243 people. Zambia, on the other hand, where I've done much of my research in childhood diarrhea, has one doctor for every 10,000 people. So there's a lot of concern right now. Confirmed cases in Africa have risen by more than 40% in a week. The testing levels are still very low, implying that many cases might be going undetected. About 415,000 tests meant that only 400 tests per million people had been carried out, which is much lower than it needs to be. I think we're watching it very closely. There's a lot of concerns, but I don't want this to be all kind of doom and gloom either. There's lots to be hopeful about. For Africa's part, governments, healthcare workers, scientists, and local communities have valuable experience in containing outbreaks already. The population is much younger than in other parts of the world, with a median age of 19. And so the lower number of deaths we're seeing so far could be attributable to that or climate-related factors. I think what's even more likely is that most countries have already taken decisive action to slow the spread of the virus. So there's been a lot of examples of really good leadership, and they shut things down and went into lockdown relatively quickly, and they're ready to do more. There's still a lot we don't know, and like I said, it's still early in the process. So everyone's watching closely, trying to ramp up testing and health systems capacity, and putting plans in place to minimize some of those secondary effects that I talked about. But success really requires an international effort. Effective containment measures carry huge costs to the health system, to economies and livelihoods, and in a lot of low and middle income countries, that capacity just isn't there. So wealthy nations like Canada can help. For example, by making sure that critical supplies don't go to the highest bidder. We also need to include poor countries in the preparations, especially by devoting more foreign aid to building up their primary healthcare systems. And that's, I used to work for CEDA, for the Canadian International Development Agency, which is now Global Affairs Canada. And Canada's always been a leader in that space, and we continue to be today. So we should all be very proud of that. If a novel virus appears in a poor country, we want its doctors to have the ability to spot it and contain it as soon as possible.
All right, so we only have a little bit of time left, and there's two questions that I definitely want to get to. And this one is one that I'm really interested to know about. And you talked a little bit about how the world is doing its best to learn as much from this experience as possible. I want to know, in the next 5 to 10 years, what will we have learned that we can implement and be more proactive so that, there is going to be a next pandemic. How can we ensure that it's not as severe as this one has been? What can we do as individuals, and what can we do as businesses, organizations, and governments?
I think from a global community standpoint, innovation is going to be key, not only to limiting the damage, but to ending this thing and rebuilding in a more sustainable and kind of future savvy way. There's a lot of opportunity to rethink the way we're doing things right now. Vaccines, diagnostics, and medicines are only the beginning of that innovation. We're also going to need new policies and platforms and approaches to limit the spread, minimize damage to economies and well-being of these kinds of events, right? So after this, and all of the lessons we'll learn, the world, I think, will inevitably be far more ready to deal with the new emerging diseases with pandemic potential, unless it starts tomorrow. But people living in developing countries still live in societies and have health systems where it can be difficult to intervene rapidly and effectively. I think it's reasonable to expect people will demand improvements in the quality and coverage of their public health systems, ensuring universal health coverage is in place, social support and medical care, that these are human rights, greater attention to managing the secondary effects these kinds of events have, and more heed, I think, to be given to advice of scientific experts. I think a move towards localization and strengthening local capacity, having stores of personal protective equipment and response, products used in the response. I think all of that needs to be part of local capacity strengthening. There's clearly a need for strengthened international collaboration and coordination, which I think will require new ways of structuring and funding our most important multilateral institutions, with low and middle income countries and private sector and citizens playing a greater role. In other words, I think we need to ensure that basic healthcare reaches everyone, everywhere, so that outbreaks can be discovered more quickly. And we need organizations like the WHO to remain funded and healthy and strong, so that, they can coordinate global responses. For the majority of my life, working or otherwise, I've done all that I can to establish relationships with people from and in other countries and cultures. Not only has it been fun and enlightening, it's also necessary, right, to strengthen the global safety net against, I'd say, most of the major threats to human existence today. Whether the next global pandemic or global financial collapse or World War III or climate change or extreme poverty, whatever, all of these are examples of clear and present dangers that can really only be addressed through global collaboration and partnership. And that means between businesses and governments and NGOs and civil society and academia, etc. So my short answer is we need to have a more global and collectivist mentality and lens, and we need to start seeing the other as part of ourselves. You asked about the kind of bigger kind of global response and then the individual response.
Right. Yes. Yeah.
And I guess at the individual level, it's somewhat related to what we can do, at the global level in terms of seeing others as ourselves. This answer might come off as somewhat glib, but I think one of the most important things we can do as individuals is to make sure we're supporting the right kinds of institutions and electing the right kinds of leaders who think about the big picture and understand our interconnectedness, and see things from more of a systems perspective. And certainly that's not to take away from our own individual actions, which of course are key. We need to be operating at both of those levels. And so with regard to our own actions, I think it really comes down to living more conscientiously and thinking about how our individual actions can impact the whole of society. What we're doing right now, the sacrifices we're all making, staying at home and giving up some of the luxuries that we've become accustomed to and perhaps taken for granted, is a great example of that. We know that what we're doing is for the greater good, and that our discipline and sense of responsibility in doing our part to care for the whole of society is making a difference. So I mean, I think cultivating that sense of responsibility, staying home when you and your kids are sick, washing your hands and maintaining good hygienic practices, which for many people in the world isn't as straightforward as you might think, eating less meat and thinking about our choices as consumers. Where are our products coming from? How do they get to us? Many of them reliant on deforestation and thereby the threat of emerging diseases, which are very closely linked. Understanding these concepts of kind of a one planet economy these are within our own capacity and control. And I know that some of these things can seem far removed from our own individual actions, but they're not. You know, we can't change these things if we as individuals don't change our own behaviors. So becoming more aware of these relationships and complexities, rather than living happily in our bubbles, and ensuring this awareness becomes. Those are my daughters.
Oh, good. My kids are upstairs with mom.
Yeah, they're supposed to be, you know.
Let me out.
So, yeah, I think becoming more aware of these relationships and complexities, rather than living in our bubbles, and ensuring this awareness becomes kind of second nature to us as individuals, like knowing our times tables, is something I really think we need to focus on and pass on to our kids.
And final question, because I know your kids are rearing for dad. Come on, dad, be done quick. Can you tell us some of the work you and your company are doing to assist organizations and governments, and maybe speak to some of the organizations that you're working with right now as well during this global pandemic?
Sure. Well, I guess they're kind of two main key ways in which we've engaged on this. So the first is that we've been commissioned by the government of the United Kingdom to conduct a study looking at our global health R&D systems for product development. So in many cases, global health products like diagnostics and therapeutics and vaccines, particularly for diseases that affect the poor, fall into a situation of market failure, where it's not profitable for big pharma to invest in the development of these products. This has resulted in situations like the 1090 gap, where less than 10% of worldwide resources devoted to health research are put towards diseases that account for 90% of all preventable deaths worldwide, and vice versa. Specifically, diseases that affect the world's poor living in developing countries. To address this market failure, organizations called product development partnerships, or that's a model which uses pooled funding from international donors to cover the cost of the R&D, or established to fill this kind of critical gap in the market, and have been relatively successful in increasing the number of products being brought to market to address global health needs. So this pandemic has brought to light the critical importance of having strong global health product R&D systems in place. Development, distribution, and adoption of new health products are really important in controlling diseases that affect the public's health. But there's still a lot of gaps in the system, and we've established to deliver these functions globally. So examples include things like laboratory and clinical trial capacity in low and middle income countries, a lack of insight into the regulatory approval and distribution pathways in various countries, timeliness of approvals and recommendations given by public health authorities, limited sharing of information, lack of coordination and prioritization, normative guidance on what products are needed and why, not to mention the market failures and disincentives that still exist to kind of galvanize action, right? And the various products being developed for COVID-19, with some obvious caveats, right? There's a lot of focus on it right now, and so there is money coming in, but they're bringing to light a lot of these gaps in the systems we currently have. So there's a lot to learn in terms of how we can improve these systems, not only for COVID-19 products, but for products that will help address neglected diseases like tuberculosis and malaria and HIV and diarrhea and Ebola and other infectious diseases, right? That already exist or will emerge. And so working with stakeholders like the WHO, the Coalition for Epidemic Preparedness Innovations, which is leading 8 of the current most promising COVID-19 vaccine candidates. Novartis, the Bill and Melinda Gates Foundation, and others were exploring how government donors and other funders should optimize their future investments in global health R&D for the greatest impact. A good COVID-specific application coming out of this is the recognition that there's no global allocation system based on both sound public health and ethical principles to decide how we distribute a vaccine once it's ready. It can be based on, it can't be based on which country happens to develop a vaccine first, and so has to be treated as a global public good, right? It's a bit of a real world prisoner's dilemma, right? And we're already starting to see some countries talking about, taking nationalistic approaches to it. But if we don't put in place a fair system, we'll never end the pandemic. This is, in this situation, the way we all benefit is if the vaccine is allocated to where it's needed the most. For example, where there are those uncontrolled epidemics and for those at highest risk, their protection becomes our protection. And to do this, we need international collaboration rather than competition. So what might that system look like now and for future pandemics? That's something we're exploring. The second project we're working on is an online platform to track all of the amazing innovation that's coming out as a result of this pandemic, not only in the health space, but across multiple sectors. It's something we're tentatively calling the COVID-19 Innovation Archive. We know that historically, these types of global changes and historical events have spurred a tremendous amount of innovation, and this pandemic will be no different. And so we're attempting to crowdsource, profile, and map innovations resulting from the pandemic from around the world. One, just to bring that innovation to light, and two, so that innovators and countries and decision makers who are interested in the response can learn from what others are doing and potentially adapt in their own contexts. I'll stop there.
So this has been an absolutely fantastic conversation, and really it's important for everyone to understand that we really are all in this together. Both now and in the future, that we all need to work collaboratively to ensure that everyone is safe, my family, your family, and a family around the world. Thank you so much for the work that you, your company, and others like you who are working day in and day out to ensure that all our families are safe. So definitely appreciate you and the work that you're doing.
Thanks very much, Carlos. I appreciate it. Yeah.
And and with that, we have come to the end of the interview. It has been an interesting one. If you've watched all the way through, fantastic. You are well knowledgeable in the subject now. But yes, Dr. Ramchandani, thank you so much for your insight and sharing your experience with us. And thank you, Warriors, for tuning in. We didn't have an opportunity to go through all of the questions that have come in through social media and through some extra ones that we had in mind as well. But there's going to be an accompanying story that goes with this video. So if you watched the video and you'd like to learn more, or if there was perhaps a question we didn't cover, that there's going to be a written story that comes out that will delve a little bit deeper into some other aspects of the work as well. So with that, thanks again, stay well, and we'll see you on the next one.